In the meantime, while we're solving that problem, Judy, can you give us an affirmation? Seems like we're having a technical problem.
Michelle or Mitchell Simmons.
Hello. Oh, okay.
Hello, sorry about the delay. I'm having internet issues, so it cuts off.
Hello.
I'm trying to see if I can share the document.
Yes.
And if not, then I'll just go ahead and briefly speak, and it doesn't look like I'm able to. So while everyone is working at home more and homeschooling, I wanted to talk about improving indoor air quality and airflow. Some of us live across the nation in hot areas and in cool. One way we can achieve better indoor air quality is through outside air. And you can do that by opening screens and windows to try and achieve cross ventilation. Sorry, I'm trying to read my notes as well.
I don't think I'm muted.
Is it muted still?
You're fine.
Okay. Yes, by opening windows indoors when possible, opening windows indoors and/or opposite sides of the room to achieve better cross ventilation. And also, I just want to know, please do not open doors or windows if it is not safe, meaning outdoor air quality is not good. It's high in heat like Houston and California right now, and just generally not safe. The next issue I would like to speak on is running your air conditioner units if you do have air conditioner units, and that could be central air and or window units and or wall mounted units. The most important thing is to have your units serviced if you have not done so in 2020. I know sometimes we don't like people to come and service, come in our area or space, but it's very important to have those air conditioning units cleaned and checked. One thing related to running the air conditioners in your home and improving ventilation and indoor air quality is changing the filters in your air conditioner is key if you have not done so. I want to talk to you about two specific types of air conditioner. One is air conditioner filters, I'm sorry. One is the general type of air conditioner filter, and there are several types. You have your basic flat standard air conditioner filters, which are fiberglass, and then you have corrugated air conditioner filters, which typically are higher in rating. One would be MERV. It's MERV efficiency, which is minimum efficiency reporting values, which is the minimum standard. And then you have HEPA filters, and I'm sure everyone has heard about HEPA filters, which are high efficiency particulate air absorbers. And they typically are in commercial grade air conditioner units and or running in higher grade filters in air conditioners. And they're also in air diffusers. With changing your air filters in your home, if you have not done so, I would say take a look at your air conditioner filters. If they're dark or moldy or anything, you want to replace those quickly. EPA recommends during this COVID time, though, that you have a minimum efficiency rating on your air filter of at least 8. And what that does is stop particulates, dust, pollen, pet dander, and things that really affect your unit, multiple occupancy. So if you have two or more people living in your home, depending on the size of the space, children, if you smoke, again, pets, if you live in a high density area such as Los Angeles, Chicago, New York, you really want to check those and check them once a month. Recommended standards for changing your air filters typically are every 30 to 60 days, depending on the factors. But again, during this COVID time, you want to check those monthly and probably replace those 2 to 4 months. Let's see. Also, I wanted to talk about portable fan use and using your ceiling fans in your home. Um, I don't know if most of you know, if you have ceiling fans, I see one going, you have two settings. You have reversible well, clockwise and counterclockwise. It's kind of like the old adage of spring forward and fall back. So if you think about your fan going in a clockwise position, that's spring and summer months. Fall and winter, you want to go counterclockwise. It's recommended right now that you run your ceiling fans in a counterclockwise position, meaning fall and winter settings. And what that is going to do is to disperse the air upwards and out to your walls and not blow directly on people, which you don't really want to do, especially if it's multiple people in your home. So do counterclockwise with your ceiling fans. With portable fans, you don't want to place them directly on people. You want to kind of avert that if it's multiple occupancy. To get a good airflow, say if you're in an apartment, if you're able to open a door or a window, you want to place that within 5 feet if possible. Again, not directly blowing on anyone, but to kind of get the flow circulating towards a bedroom, kitchen, or office space. If you're in a home that's single story, I would recommend opening a front window or door and a back window or door and running ceiling fans and or portable fans through to get air flowing. Uh, Also, if you're in a two-story home, I would open a window or door downstairs and then one in the opposite direction upstairs to get airflow going through that way as well. Um, Bathroom fans and kitchen fans run as often as possible. We really don't think about getting air out of our bathroom and kitchens often unless we're in there, but that also helps with airflow, moving the air out. So that's a good thing to do. Um, Use of portable air purifiers. Some people use dehumidifiers and humidifiers. I will say they have high HEPA filters, but as with air conditioners, you need to change those filters often. And with that, you need to be careful when doing that. So if you are changing the filters in your air purifiers, you're cleaning your dehumidifiers and or removing waters from your humidifiers, you want to wear gloves and a mask. It's very important that you do that. And also clean those items often and clean your ceiling fans and your portable fans as well. That's really all I wanted to cover. And questions?
Let me ask you a couple of questions, Ms.
Sure.
Bethany. I certainly appreciate your presentation. I've read articles that in some commercial settings, is there any risk and danger of air conditioning actually causing more risk in an enclosed space, such as a restaurant or a place like that? Are there any problems there?
Actually, yes. So actually, the EPA, the CDC, and ASHRAE have been conducting studies. Commercially, you're actually at less risk depending on the occupancy because those systems are designed to for air filtration. So you have HEPA filters, you have redundant systems that pull air up and away from people, whereas in our home, we don't, and they're required to be serviced. So there are codes mandating that they be cleaned, that the filters be changed. We don't do that in our home. So we're actually more at risk at home than we are in commercial spaces.
Okay. And I'm also wondering if you'd be kind enough to comment on airplanes in flight and those little things that sit up above your seat. Should they blow on you, or what's the
Yes,
risk
they
of
do
the
blow on
airplane?
you. They do. So the limited study that I've been reading on planes, and I have not traveled because of this. I don't want to dissuade anyone. You do need the airflow, but it's not outside air coming into those planes. It's recirculated air. So I would turn those vents on as little as possible and make sure that the air is not blowing directly on you. So, we hate to blow air on someone else, but push it towards the seat in front of you. But it's recirculated air. That's the risk on an airplane.
Well, thank you so much. Michelle, are there any questions in the chat box? Are you muted, Michelle?
Yes.
I see you shaking your head.
Yes.
Uh, Judy, can you read the chat box? I apologize for the technical issues. We'll come back to the chat box as
Okay.
soon as we
I'm
get.
right. I'm sorry. I'm just waiting for, I was waiting for Simon to unmute me. So here we are. Any suggestions with regards to the CPAP users
The
Actually,
respiratory units we use for COPD.
or
Uh,
sleep apnea?
so I can answer that question. They need to be thoroughly cleaned on a daily basis, and they are safe if used. But it should be emphasized that you don't want to wait 2 or 3 days to clean those. And we'll have information on those we can put on the website. There are a lot of people who use those. And so we'll do any other questions there in the chat box?
Yes, I see one more. There are reports that the air filtration on airplanes is actually quite good with frequent air turnover. If you must fly, are there areas of the plane that are safer to sit in, for example, the front or back?
yes, that I don't know. Like I said, the studies I read, because it's recirculated air. It's differing opinions. But no, I don't know. I couldn't
Okay.
answer that.
There were some reports that even when people are sitting across the aisle from you,
Yes.
there is potential danger and cross contamination. I agree with her statement that uh, blower in front of your seat should not be directly on you, but it should be on. But you do want it to move the air. She is also very astute in saying that the air circulated inside planes is mostly through HEPA filters and does clean at some point. But if you have to fly, you do want to still distance as much as possible. I don't know that any one area is safer than the other, but if I'm on a plane, I would probably sit toward the back, but not necessarily near the lavatories or restrooms. But I prefer not to fly. What I've advised people in my family that are traveling, that they, if they're self-isolated at home, that they drive if that's practical, and quarantine by driving and not fly public transportation if that's practical. And if you're on a plane, you do need to wear a mask. Now, we tell people to wear regular surgical masks, which will help protect other people. It won't particularly protect you. But if I did fly, I'd wear the closest thing I could to an N90 to an N95 mask or a KN95 mask as a health professional. But I would wear that, which is protective because of the filter. And we can open the floor on that a little bit later. Mr. Russo, I thank you for your presentation, and hope you can be around to answer questions as we go on. Thank you so much. And also your other famous relative is on, and I will definitely call on him for some other engineering input, especially concerning UV light and its effect and protection. I'd like to introduce my good friend as our next speaker, who talked about, as she assumed the presidency of the National Medical Association, the North Star as a target of our direction. She is a very impressive young lady. She is a general in the military. She has been a leader in healthcare. She's a medical oncologist. I'd like to introduce Dr. Edith Mitchell for our next talk. Dr. Mitchell, please take the floor.
Thank you so much, Dr. Maxey. It is always good to work with you and to speak with you. I am sharing my screen now. And can you see my screen?
Right now we see a Zoom notice. It just says Zoom.
There should be another button in the lower right. You actually have to press to share your screen.
And it does say that, there we go.
Do you see it?
It
I
went
saw
away.
it, it went away. There
Yeah.
it is.
Okay. So I am going to talk about two topics that are very dear to me. And that is, I'm an oncologist, so I talk about cancer, I take care of cancer patients, I do cancer research. And in this COVID time, we are really very interested in making sure that patients continue and obtain the best in cancer care, but also to continue screening with their primary care physicians so that there is early diagnosis of cancer. We're all concerned about the fact that many institutions have forwarded their care toward the acute care of COVID patients, but also many individuals have refused to go to their regular doctors because of the risk of COVID. And what I want to tell you today is a little bit about cancer outcomes. And while we're talking about the future with telemedicine now, that we're all using telemedicine, but I want us to continue assessing the past through the rearview mirror. So don't forget about your rearview mirror. Now, telemedicine is very prominent this year, and in some situations, there has been an increase of telemedicine usage over several 100%. And in my own practice, while in January of 2020, we had about 400 telemedicine visits, yet in July, we had almost 5,000 telemedicine visits. So using telemedicine, and I started using telemedicine in the military, where we were connecting with troops in disparate conditions and faraway places. The astronauts, we've also used telemedicine with the astronauts to continue evaluating them and their health in space. But getting back to cancer, what we know is that over the last 3 decades, we've decreased cancer deaths by 29%. So a decline in the death rate of cancer patients by 29%. And that's really very important and dependent on a lot of people. Yes, we do have new cancer treatments and innovations. However, it is also important for our community to avail themselves of cancer screening so that early cancer detection can occur. The earlier we find a cancer, the better the likelihood of cure or positive outcomes. So it's really up to everyone, healthcare institutions, the cancer physicians, and all physicians and clinicians, as well as those in the community, community advocates and everyone, to undergo screening, to evaluate their information, to participate in clinical trials, so that everyone has the best opportunity for a good outcome from cancer care. It is well recognized that African Americans in the United States have higher incidence rates for multiple cancers, as well as higher death rates. The fact is, Black men have the highest incidence of cancer in this country, and therefore, for African Americans, it's very important that we undergo the recommended screening test, the right test at the right time, and therefore increase the chances of better outcomes. For Black women, white women have higher cancer incidence rates, but Black women have higher death rates or mortality rates from cancer. And while we have increased cancer studies, cancer death rates have declined over the last 3 decades. Still, African American men, Black men, have the highest incidence, the highest death rates from cancer in this country. And therefore, it's up to all of us to address this. We've got to get our husbands and our brothers and our fathers and whoever else is in your life in for the appropriate diagnostic studies as well as treatment. Now, the American Council on Graduate Medical Education, which all doctors have to go through graduate medical education at some point. So ACGME is recognized by this sign, is in charge of that. And ACGME just this year has come out to say that we need diversity in the workforce, so we need more Black doctors. We need equity in terms of outcomes for patients. And we need inclusion to make sure with our culture, we're getting everybody in where they need to be. And therefore, all of these things are included. And what we can say is equity matters. So it's really up to clinicians to look at everything. And for everybody involved in medical education, we need to make sure that we have diversity, equity, and inclusion. And with ACGME, just this year, they have put out a plan that everybody can be involved. You've got to have innovative strategies. And then once we develop those strategies, we've got to implement them appropriately. And Dr. Maxey, this program today is a part of implementation of cancer care so that we can address the outcomes in the Black community. We've got to change the outcomes such that we can say that African Americans no longer have the highest incidence rates, the highest death rates in this country. So with telemedicine being more utilized this year, it is a technology that is very important. It's been around for many, many years, but more so utilized in healthcare delivery just in 2020. And what we're doing with telemedicine is to understand patients and clinical trials participants and what the patients want. And rather than seeing telemedicine or telehealth as a separate entity, it's really integrated into the fact that it is a component of the healthcare continuum. And therefore, we can assess needs, services, settings, type of care. We can incorporate inpatient and outpatient setting components so that individuals can talk with their clinicians, but also can integrate family members or other trustworthy participants in the care. And we have to assess how can we use this in medicine for clinical trial options, because we don't want to stop clinical trials because of the pandemic. We've got to be innovative, as ACGME says, in our strategies and make sure that we are participating and have the maximum information, not only for our patients and the clinical trials participants, but what I do is incorporate the primary care physician into the program so that it is really a part of the healthcare continuum. And the factors we have to work with, both the patient as well as the clinical staff, and for the physicians, not only for the physicians, but all members of the staff and healthcare team, so that we know what we're doing. We've got to know which platform to utilize and what works best in our communities, building trust with our teams, and expand that to patients. And I actually do clinical trials on my computer. I take care of patients on my computer, and we have ways of patients meeting us and being involved in their care. We've got to look at what are the barriers and challenges. One of the things in Philadelphia is the technology that allows access for computers. Many, especially geriatric or the older population, might still be using flip phones. And we've got to learn who uses a flip phone still and how we can use their phone to help them with their medical care and to continue their health care, making sure the patients are getting precision medicine, getting the right medicine for the right patient at the right time. We also want to make sure that we know what the telehealth offerings are, the state guidelines, and the insurance coverage to make sure patients don't receive a bill for which they were not expecting or aware of. So we have to know the billing for the states where we live. And for me in Philadelphia, my patients come from New Jersey, Delaware, Pennsylvania, and New York. So I have to make sure that my staff knows all of the billing considerations around telehealth, so that no matter where our patients are and where they're living, they get the best care. And we also, it's very important to define the telehealth processes and access to increase awareness about this option for not only healthcare delivery, but also to make sure that our clinical trials continue, and therefore for clinical trial participation. It's very important, especially for African Americans. While African Americans constitute 13% of the population, only about 3 to 4% is the African American population in clinical trials. So if we are to know how the new technology applies to Blacks in America, the African American population, we need to make sure that individuals are participating in clinical trials. So in conclusions, what we can say, first of all, telemedicine is here to stay. It's a very important part of medical care. It's important that patients understand that they can access medical care through telemedicine. It's very important that clinicians, physicians, and others on the clinical care team know about the offerings of telemedicine, how to use the technology, and how to maximize this for the care of patients. Telehealth can provide the elements that are needed to allow for informed, patient-centered, and value-congruent decisions. So this can all be incorporated into our usual healthcare delivery. Telehealth can be used to educate patients and professionals about clinical trials and facilitate trial planning. so we can accomplish all of this through telehealth. There are, of course, some procedures that we know patients do have to come into centers. For example, a few days ago, I was talking to a patient about a colonoscopy, and he asked me if he could get it over telemedicine. Of course, that can't happen. So there are some things patients do have to come in for procedures. But telehealth can advertise, it can recruit, and it can walk the participants through the informed consent processes so that we can use telehealth not as an adjuvant, but as a part of the healthcare continuum. Telehealth can allow for continued contact with patients and to stay in touch with clinical trial participants. And this can actually improve cancer clinical trials care, uh, clinical trials recruitment, and retention. So overall, despite the COVID-19, yes, we take care of the infections that patients unfortunately experience, but we've got to remember that routine care must go on, and individuals need to utilize how we can use telemedicine to forego visits if needed. But if visits are needed for x-rays or scans or procedures, our healthcare institutions have safety guidelines that protect both the healthcare delivery team as well as the patient. So it is safe, and therefore individuals should not put on the back burner medical conditions that need attention. So with that, Dr. Maxey, this is something that I've developed with our center and our cancer center, is that we utilize everything in the community, and we know our community, and therefore community engagement allows us to focus on our specific population, but we need to bring into the center with us the community outreach and education, so that patients and community advocates and everybody in the community knows and understands. We have to develop partnerships and strategies to overcome these barriers. And just like this program today, I want to thank you for a program like this where we can communicate with the community, with clinicians, with everybody, so that we've got that partnership that allows us strength and communications. And of course, our scientists, the basic scientists, our clinicians and clinical scientists, and then our behavioral and epidemiologic scientists, so that we have our data. We know who we are. We know what goes on in our community, and therefore we can bring all of these individuals and organizations together in a circle, and therefore maximize our opportunities and outcomes for our community population. I thank you so much for allowing me this opportunity to speak.
And I thank you so much for your astute presentation. And while Michelle looks at questions in the chat box, I have several things I'd like you to address. Why are Black men, especially, but Black people in general, at such high risk for various types of cancer? And in light of our hero and superstar dying a week ago with what was identified as colon cancer at age 43, why do we have so much risk of cancer, doctor? And what can we do in our daily life to help mitigate that?
So there's a lot of research ongoing, and there are two factors in relationship to the unfortunate and early demise of Chadwick Boseman. First of all, African American men, all African-American men have a 47% higher chance of dying of colon cancer than white men. 47% higher. We don't know exactly why. We do know that genes don't play a total role. Genes account for about 2% of inherited forms of colon cancer. There are theories about the bacteria in the gut and the influence of bacteria based on food and other intake. So alcohol might play a role. Fats in the diet might play a role. All of these are being investigated. So we don't know exactly why. What we do know about young patients is that for all young patients, whether they're white or Black, there has been a 2% per year increase in colon cancer in young patients over the last decade, so 2% per year. The youngest patient that I treated was 15 years old with metastatic rectal cancer at the time of diagnosis. It is thought that perhaps fast food and obesity might play a role in the younger patients developing colon and rectal cancer, but that's an area of research. It's also recognized that young patients present with widely metastatic disease or more advanced disease at the time that they come in to see us. So for Chadwick Boseman, it has been announced that he had stage 3, which is advanced colorectal cancer at the time of diagnosis 4 years ago. And for many young patients, even for the clinicians, Dr. Maxey, when they come to a doctor complaining of some abdominal pain or other symptoms, many physicians don't count it as a big problem, and therefore colorectal cancer is not considered in the initial assessment of a young patient with abdominal symptoms. So for young patients, we are recommending that physicians, if a young person comes in complaining of abdominal complaints, don't put it off. Consider that it could be colorectal cancer. I hope that answers your question.
It does. It does. Michelle, are there any questions in the chat box?
Yes, I've been listening to Dr. Mitchell's responses and integrating them into these questions. So I think I'm going to go with, beyond socioeconomic factors, can you comment on cultural and genetic factors that might be increasing the risk of cancer in Black people?
So I think I've mentioned the genetics, that it's about 2% of all colorectal cancers. So genetics does not appear to be playing a major role in the higher incidence and mortality rates in African Americans. We do know that obesity, high fat intake in the diet, alcohol in the diet, lack of fiber, fresh fruits and fresh vegetables, all of these things could be playing a role. So the socioeconomic effort or socioeconomic contribution is probably the major contributing factor, because for most individuals, they eat what they can afford to eat. And in many areas in the country, food deserts where there's no major drugstore for medications, but also major supermarkets, and the lack of availability of fresh fruits and vegetables. All of these things can be contributing factors.
Would you say those same risks would be the contributing or major contributing factors for breast cancer in Black women?
It could be a part of Black women, but Black women, there's something different. Black women do not have an increased incidence of breast cancer. It is approximately the same as whites. What we have, however, is a higher incidence of triple negative breast cancer in Blacks, and in some areas of the country, it's 39% higher than that in whites. I had one of my residents some years ago evaluate our patients at Jefferson over 20 years. And what was found was in Philadelphia, a 20% higher incidence of triple negative breast cancer. Triple negative breast cancer has fewer treatment options. It's a more aggressive tumor that is more likely to spread to other parts of the body real quickly. And therefore, lots of research ongoing now on why there is an increased incidence of triple negative breast cancer in Blacks. But how can we develop new treatment paradigms, new treatment drugs that are used to treat triple negative breast cancer? Because the usual drugs that have been developed over many years, such as tamoxifen, those drugs don't work for triple negative breast cancer, and in fact, can make it worse. So, excuse me, we're recommending anybody with triple negative breast cancer should at least obtain a consultation in a center where there's research ongoing in triple negative breast cancer. I've been doing research in triple negative breast cancer basically all of my career, and I have lots of patients, triple negative breast cancer, who are alive after 20 or more years. So it's so important that patients, number one, know whether they have triple negative breast cancer, but at least obtain a consultation at a major center doing research on triple negative breast cancer, so that we can get our women into the right treatment trials.
Thank you, Dr. Mitchell.
I have a question. I used to be a nephrologist, but now I'm doing primary care. And in that setting, in seeing young women, middle-aged women, old women, I advocate that I always ask the question, are you doing monthly breast stuff exams? Mm-hmm. Have you had exams of with your breasts in terms of radiology mammograms? And I also tend to ask people about colonoscopies and biopsies. What would your advice be to any woman, including if there's a history of breast cancer in her family? What do we tell our ladies?
So we know that the regular recommendations, although they may differ slightly from one organization to another, but most recommend the first mammogram by age 40. Now, if there is a history of breast cancer, especially if the breast cancer occurred in a young patient, and that family member, we recommend screening, whether it's colonoscopy or mammogram, for the family member's age minus 10. So that, let's say if a woman had breast cancer at age 45, then her daughters should begin screening 10 years younger at age 35. If there's colon cancer in the family at age 40, we recommend screening at age 30. So 10 years younger than the youngest person in the family with the disease.
Thank you so much. Michelle, are there any last questions in the chat box?
Sure, let's go for this one. Can you comment on the findings in a well-known Cornell-Oxford-China study and a recent 15-year-long Oxford study where they studied 60,000 British subjects? They found 11% lower rate of cancer in vegetarians and 19% lower rate in vegans in all causes of death and from all forms of cancer, including colorectal cancer, multiple myeloma, brain, breast, lung, leukemia, and other diseases?
Yes, I am aware of that study, and I do recommend to patients that a diet consisting of low amounts of fats, low amounts of processed meats, and a higher amount of fruits and vegetables. And it's best if these fruits and vegetables are uncooked. It's well recognized that a high fiber diet, whether it's a vegan diet or whether it is one of the healthy diets, so-called Mediterranean diet, where the meat consists of mainly fresh fish, low fat, and high vegetables and fiber. So that's a general recommendation that I give to everybody because the high fiber diets have been shown to have individuals with the highest age of octogenarians and the lowest death rates as from all causes, but especially lower death rates from cancer. So if you want to prevent cancer, it's eat high fiber, fresh fruits and vegetables, low fat, especially animal fat, and low animal protein, especially if it has been processed.
Well, thank you so much, Doctor. I appreciate you, and we're going to have a lot more questions later. Um, I want to move on. Michelle.
Oh, Dr. Maxey, I'd like to tell you that we are doing another webinar on cancer, and it's the Cobb Institute of the National Medical Association. It will be on the 19th of September, which is a Saturday, and it's 12 o'clock Eastern time. But I'll send you that information, and I would like to invite all of the audience today to participate in that webinar. And Michelle, how about if I send you the link so that you could send it to other participants? But it's so important that our Black community get together and decrease the incidence rates of cancer as well as mortality rates.
Sounds good.
so
Thank you,
much.
Dr. Mitchell.
Very good. Um, Michelle, could you give us our necessary commercial?
And sure, and I'm going to defer that to our necessary Judy. Judy, where are you?
Find out.
And just before Judy logs on, I did want to mention there was a couple of questions about what is triple negative breast cancer. And there was a response that says triple negative means no estrogen, progesterone, or HR2 receptors. They thus cannot be treated with hormone receptor blockers. Are you comfortable with that definition, Dr. Mitchell?
That's perfect.
Okay, I just wanted to put that out there for people who don't have access to the chat room.
Yeah, so triple negative, negative estrogen, progesterone, and HER2. So that's the three.
Okay, thank you.
Good.
Judy, thank you.
Hello, everyone. I'm a proud member of the Black Health Trust family, whose mission is to provide credible information and insight from our community health experts. We are so grateful to the numerous health professionals that have donated their time to this dynamic Sunday program since the beginning of the pandemic. Our goal is to inform and help people of color become and stay healthy. Black Health Trust is developing the structure for a well-managed nonprofit organization, and our continued success depends on your support. We ask you to please consider a modest donation or more, as every dollar counts. Please visit our website at blackhealthtrust.org to donate via credit card or PayPal, as well as we have donor box available. See the chat box for a link, and thank you very much.
Well, thank you, Judy. I have the special privilege of introducing one of my best friends. And I have to say, many times as a physician, When I have issues, I don't have many people to go to. And, doctors don't like to have issues. At least we don't like to let people know we have issues. The same with many ministers. They don't like people to know they have issues either, but we all have issues, especially during a time of hazard like this. We are not a religious program, but we all have our own ways of faith and ways of staying spiritually and mentally healthy. And I'd like to introduce for a few moments one of my best friends and one of my teachers, who is Pastor Shavine Jones, who, as I mentioned earlier, has a master's and PhD in Hebrew and Greek. And therefore, when he speaks the word, it's with much research. And I'd like to introduce him as our community celebrity speaker for today, Dr. Shavine Jones. Can we make sure he's unmuted?
So he can unmute himself. He just has to click the button.
I'm looking for Dr. Jones. I don't see Dr. Jones.
Okay, we'll bring him back when he's available then. I'd like to introduce another speaker who joined us a bit late, and we've gone from medical oncology. We're going to go to gastroenterology, and we'll end up with surgical oncology. Dr. Fola May has an MD from Harvard. She got a PhD from UCLA. She is a researcher in health equity and preventative medicine. And she's an exciting, bright young woman that I am itching to meet. She works with another good friend of mine, Dr. Keith Norris. I'd like to introduce Dr. Fola May, MD, PhD gastroenterologist. Dr. Fola May, would you take the floor?
Sure will. Can you hear me?
Yes, we can.
Fantastic. Good morning or good afternoon to everyone. My name is Fola May, as mentioned, and I'm honored to be here to speak with you a bit today. I'm actually also honored to speak after Dr. Mitchell, who just gave us a wonderful talk. I'm going to do a little bit of a deeper dive into colorectal cancer and hopefully answer a few of the questions that we didn't get to in the chat. Thank you for the introduction. As mentioned, I am a gastroenterologist. I work at UCLA Health, but also in the Veterans Affairs. I spend about 80% of my time doing research, however, and that research is specifically in colorectal cancer prevention. And my lab focuses on disparities. Okay. So I think that this talk is very timely in what we have experienced in a community this week. And the loss of Chadwick Boseman was a great loss. He played icons and historical figures and heroes on the screen. And I think even off screen, he was someone that we really admired for his truth and his candor and for being young, Black, and gifted, and for offering our community so much hope. And we were shocked when we heard that he was diagnosed with colon cancer at such a young age. 39 is by far not what we typically would see for this disease. So in light of that, what a lot of us have been doing in the cancer community over the last week and a half is trying to increase education about colon cancer so that we lose as few people as possible from this condition. I want to start by just reminding everyone how common colon cancer is. And one of the things that's been most humbling for me this week is how many people have approached me and just said, I didn't know it was so common. I didn't know it was so common in African Americans. Colon cancer is the #3 cause of cancer in both men and women in the United States, just after prostate and lung cancer for men or breast and lung cancer for women. When we look at mortality from colon cancer, because it is a malignancy that impacts both men and women, it actually rises to the #2 cause of cancer-related deaths in the United States. And many people are shocked to hear that because we spend so much time talking about breast and prostate and lung. We don't realize that colon is a #2 killer. Early onset colon cancer is what we're talking about right now a lot in the media and in healthcare, just in light of Mr. Chadwick's unfortunate passing. I'd like to highlight that about 11% of the colon cancers that we diagnose right now are occurring in individuals who are under the age of 50, and that's the population that we refer to as early onset colorectal cancer. This has been an increase by about 45% since the 1990s, and we've started to see this small uptick in the number of individuals in this younger category with colon cancer since the 1990s. I will also highlight that early onset colon cancer tends to be more aggressive than traditional onset colon cancer. So unfortunately, when I encounter patients who are under 50 with this diagnosis, their cancers grow faster and more aggressively than the 60-year-old that I diagnosed with colon or rectal cancer. When we look at individuals over age 55 in the United States, there's actually a downward trend, as you can see in this graph here, in the number of colon cancers. And this is something that we've celebrated in public health because it means that a lot of the efforts that we've done to increase knowledge about this disease and screening has been effective. What we've noticed, as I mentioned, however, is this uptick in individuals who are less than 50. Now, mind you, the axis here, the y-axis is changing by quite an extent. So in that it's 50 to 200 here for age over 50 and in the single digits for less than 50. So these graphs are not to scale, but that's to make the point that we're still seeing the biggest burden in people who are over 50 years old. It's just this group that's rising that we're trying to understand more and more about. Where do these cancers come from? They originate in the lining of the colon or the lining of the rectum. Here I'm showing a picture of what a normal colon looks like when I'm doing a colonoscopy and when I'm looking at the wall of the colon. And this is what a polyp looks like. Polyps are very common. Over 50% of people have polyps, but there's only certain types of polyps that when we look out under a microscope, they have the early signs of transition to cancer cells. And those are what we call adenomas, are sessile serrated polyps. These are the ones that we think are most likely to, over time, develop into a colon or rectal cancer. And that's what it looks like when I'm doing a diagnostic or a colonoscopy on a patient, and I unfortunately find a colon cancer that's been growing there in some time in their colon. Years and years and years over time, these polyps can progress into this state. Dr. Mitchell has done a wonderful job of giving us some information about risk factors for all malignancies and emphasizing that these risk factors are higher in Blacks in many cases. Here, I'm narrowing into the risk factors specifically for colon cancer and for colon cancer polyps. And I like to break these into mutable risk factors and immutable risk factors. Mutable risk factors are things that we actually can change. And those are things that public health scientists like myself are in the community constantly trying to teach about. The other side, the right side of the screen, is actually risk factors that we can't change. And these, unfortunately, are very strong risk factors, but are things that we typically do not have control over. So for example, family history is one of the strongest risk factors for colon cancer, but you often cannot change your family history. As is age, as we've already discussed, age is a very high risk factor for development of cancer and polyps. And that's immutable, something we can't change over time. Male gender, African-American race also fall into those categories, as well as many other conditions and statuses that we live in. I like to focus on the other side of the slide over here, though, however, where we can look at risk factors that we can change and that we can encourage change in our community. And as Dr. Mitchell mentioned, that is reducing bad toxins in our diets. So particularly for colon cancer, we know that diets that are high in animal fats, red meat, processed foods in general are promoting for this disease, meaning that they can cause or be linked to this disease. As well, diets that are low in fiber are linked to having a higher rate of colon cancer. We know as well that physical inactivity, obesity, type 2 diabetes, use of tobacco and alcohol are also risk factors, as well as participation in screening, which we'll talk a little bit about right now. Before I do that, I want to highlight the racial and ethnic disparities we do know about in colon cancer, and this is what my lab focuses on. So first, African Americans are most impacted by this disease. We are likely to develop this disease at a young age. We also have the highest incidence and mortality of this disease. We tend to present at very late stages, and what that means is that there are very few treatment options and the survival rate is lower, and we have lower screening participation than white Americans. Our Latino population also has disparities. They are likely to present with late stage disease and to have low screening rates. Our Latinos actually in Los Angeles have some of the lowest screening rates, and many of my projects focus specifically in community health centers where we're trying to help Spanish speaking and English speaking Latinos who are unscreened. Asian Americans have lower screening rates than white Americans, and Native Americans, who are often neglected when we do disparities research, have very high and rising incidence in mortality from colon cancer and some of the lowest screening rates. I've mentioned screening. Why is it important? Screening allows us to detect and remove those polyps that I showed you a few slides ago before they have the opportunity to transform into cancer. And that's why screening can save lives. It can detect cancer early, but it also can prevent cancer altogether by removing those polyps before they have the chance to transition into a cancer. Luckily for colon cancer, we have many different screening options. The most common option is a colonoscopy right here. Again, that's the images I showed a few slides ago. About 80% of screening in the United States is done by colonoscopy. The number 2 most common test is a fecal immunochemical test, or what we call an FIT or FIT test. This is a stool-based test that you can do at home. Your provider gives you a kit, it has a small tool in it. You void a stool sample into the toilet bowl and you collect a small sample of your stool. You put it into a vial that looks like this, and in a sealed envelope, it is sent to a lab where they test for microscopic blood. And microscopic blood in the stool can be a sign of colon cancer. And then there are less common, but also widely publicized ways to screening, including the Cologuard test, which you might have seen some commercials for, CT colonography or virtual colonography. This is what President Obama had a few years ago and popularized. And then as well, the 2 new kids on the block are a capsule study. That's the idea that you can swallow a capsule that has cameras on it and it can take pictures of your GI tract all the way down. And serology studies, excuse me, I'll go back to that. This is the idea that you can do a blood test to screen for colon cancer. These 2 are very new and we're just doing preliminary studies on now. When you're in a high risk group though, although I mentioned all those options, the preferred option is colonoscopy. And I've listed here what those high risk groups are. So people with a personal history, a family history, or certain conditions, including ulcerative colitis and Crohn's disease, which are collectively known as inflammatory bowel disease. Many people ask me to, I'm sorry about that, to summarize the age at which you should start screening. Most of us are going to be in the bottom row, average risk, and that's going to be starting age 45 or 50, or African American, second to bottom row, beginning screening at 45. The societies vary on what they recommend. United States Preventive Service Task Force recommends that we start at 50. The American Cancer Society recommends that we start at 45. The United States Multi-Society Task Force recommends that African Americans start at 45. I tell everyone, start talking to your provider at around 44, with the anticipation of starting at around 45, unless you fall into a family history category or those conditions that I have listed in the second row, and those individuals will start screening at age 40 or even earlier. Despite the fact that we have all of those screening options that I've just mentioned to you, and despite the fact that colon cancer is highly preventable if we do screen, our participation in screening in this country is awful. We are not doing a good job at screening. When you compare to screening for other malignancies like prostate, cervical, breast, colon is very far behind. And our white Americans, our screening rate is 70%, which is far below the national benchmark of 80 to 85%. And when you look at Latinos, and this is United States data, their screening rate is only 50%. So there are many different groups, including Black American, Asian Americans, Latinos, and Native Americans that we need to do a lot of work. And many groups, including my group here in Los Angeles, focuses specifically on this problem of screening in the community. Why are screening rates low? This slide has a lot of information on it, but I'm going to just try and pick out a few things that I think are most important. The number one thing I want to say is that it's not always the patient's fault. There are problems at the provider level and at the healthcare system level as well that are contributing to low screening rates among minorities. When we talk to patients, oftentimes they just didn't know. Too often I'm meeting Black males in my clinic who are telling me that I thought my prostate exam was what I needed. I didn't understand that colon cancer was a big deal either. So knowledge is a problem. And then there's also fear of the diagnosis and fear of the procedure. We know in particular that in Black men, there's a lot of hesitancy about colonoscopy and the invasive nature of the study. And in many cases, that prevents people from participating in screening. But there are problems with our providers as well. There are many studies, including a study that we did several years ago, that shows that providers are less likely to recommend screening when it is a Black patient in front of them. So lack of a recommendation is a problem. And we know that bias, whether that's intentional bias or subconscious or unconscious bias, is playing a role in how we care for patients. At the health system or policy level, there are many factors as well, including funding for federally qualified health centers and community health centers, policies. Luckily, right now, many people have access to healthcare coverage, but that isn't always a given in this country. And then there are some parts of the country where there's just poor access to colonoscopy. All of these things, however, are deeply rooted in what we call social determinants of health. So although I split those up into patient, provider, and system, as Dr. Minshall mentioned earlier, these are all rooted in the reality that where you are born, in many cases, predicts your health outcomes. If you are born in a neighborhood where you cannot get out and safely exercise and exert yourself physically, you are more likely to have obesity, and you are more likely to have many cancers, including colon cancer. If you are born in a place where there isn't a medical clinic nearby, then you are not likely to have access to screening. You are likely to be diagnosed with this disease late, and you are likely to die from this disease. And those social determinants of health are deeply rooted in systemic racism in our country that have been here for hundreds of years. So I alluded a little bit to the work that we do because many people ask, so what's being done, especially this week? What is being done about this problem? Young Black men, young and even older Black men are dying of this disease at a higher rate. In our group, we specifically are doing a lot of work to understand the epidemiology of colon and rectal cancer. We have several studies that are trying to improve screening rates. We work with several federally qualified health centers here in Los Angeles and also in the San Diego County to try to improve colon cancer screening participation. And then we also are looking at disparities in treatment. Because if you're screened and diagnosed, there's still several steps that need to happen for you to survive this disease. You need to find a doctor, you need to have a colectomy. Oftentimes you need chemotherapy or radiation. So getting people of color connected to health systems where they can get appropriate care and there are no disparities in treatment. And then some of the really interesting studies that we're starting to do and that we're looking for more funding in have to do with things like microbiome and diet in colon cancer. And how can we alter the microbiome, which are the natural bacteria that live in your gut and in your colon. How can we alter those bacteria so that you reduce your risk of developing colon cancer? We do those studies in community health centers. I'm also a faculty in the VA, so we do national studies in the VA to understand how we can improve screening and reduce disparities. And then many of my studies are also at UCLA Health. The other thing that we are actively involved in is a colon cancer campaign. Every month, every March, every year, we celebrate Colon Cancer Awareness Month. And this is when activists, scientists, survivors, family members come together to spread the word about the risk of colon cancer and the risk of dying from it. And every year in March, we have a large campaign based out of UCLA that does events throughout the Los Angeles community to raise awareness and to give people access to screening. So these are some pictures from some of those community events that we've been doing. We actually travel around with this giant colon. It's a big blow up colon and you can see people walking through it. Actually on the wall of that giant blow up colon are polyps. So I can stand in there with a patient. I think one of my team members right here is explaining to a group of patients what a polyp looks like when it's growing on the wall of the colon. Again, these are just to raise awareness and to let people know that by removing these polyps, we can actually improve your likelihood of survival. I'm done, but I want to say one more thing. Everything that I've said about screening today might not have helped Mr. Bozeman. He was diagnosed at such a young age that unless he had a family history of disease, we would not have caught it with screening. So because of that, we like to emphasize now the importance of being aware of the symptoms of colon cancer. So if you have blood in your stool, if you have a change in how your stool looks, meaning that it goes from a normal shape to a pencil shaped, or new constipation or diarrhea, if you've developed loss of appetite, if you've developed weight changes that are unexplained, these all may be signs that colon cancer is already developing in your body, and those should not be ignored. As Dr. Mitchell mentioned, we need to pay attention to these symptoms and we need to seek attention. Even now, during COVID, you need to be seen so that we can go ahead and risk stratify you, do your colonoscopy, and make sure that you don't have colon cancer that's developing. So I just want to leave with those parting words. Thank you.
Thank you very much, Dr. May. I'm thrilled about your talk and your information. One of the things that you mentioned applies to many of us. I'm a young Black male, don't laugh, and I went to have a colonoscopy, and even though I'm a physician, I saw this long tooth, and I had some real concerns. Would you just in a practical way describe the actual process, and in particular uh, the process where there's lack of memory of the procedure?
Yeah, which I'm laughing, but that's the best part, isn't it?
Yes.
They put you to sleep for it?
So this is how, no one loves a colonoscopy, okay? I try to sell it sometimes by saying that I'm giving you a free colon cleanse, but even that doesn't go well over for most people. What we do is the whole process actually starts a day or two before the procedure. You need to be on a clear liquid diet. You can't have any solid foods. No one likes that part. And then you need to take a heavy laxative that's pretty much going to keep you on the toilet for about 12 hours. The reason why we do that is because we need to clear your GI tract of all the stool that's in there so that when the gastroenterologist does the study, we can see the actual walls of the colon, like the picture I showed. So a day before the procedure, liquids only. The night before the procedure, you start the laxative medication. You're on the toilet most of the night. Some doctors will even have you take a little bit more of that laxative when you wake up in the morning. After that, you come to the clinic, the hospital, or the procedure unit. You need an escort. So we're getting into disparities again, right? A lot of people don't have an escort. A lot of people can't take a day of the week off from work. But if you're fortunate enough to be able to do this on a Monday through Friday, you come in with your escort. The escort waits for you. We hook you up. We give you an IV. We explain the procedure to you. We do a consent form. And then I take a long black tube. It has a light and a camera at the end. My anesthesiologist will give you medication so that you are either in twilight with conscious sedation or completely to sleep with propofol, which is anesthesia. And that will depend on the health system where you're getting the procedure done. Once you are comfortable or once you are asleep, if you're lucky, then I start the procedure. I insert the tool into the rectum and I start looking for any polyps. The procedure itself only takes about 30 minutes. But sometimes I encounter patients that have 10, 15, 20 polyps. So that can take upwards of an hour to take all of those out. When I take a polyp out, I use a small tool that takes the polyp out. You can't feel it because you actually don't have sensory nerves on your colon that feel us grabbing them. We put them into small containers and send them to our pathology colleagues. And our pathology colleagues, a day or two later, will look at it under a microscope and they will tell us whether there are any signs of early cancers in those polyps that we took out. And about 25% of people, there is an adenoma, which are one of these high-risk polyps. And we will tell those individuals that they need to come back in 3, 5, or 10 years to have their next colonoscopy. So everyone complains about the prep the night before. Most people, I wake them up after the procedure and they look at me and say, "Doc, when are you going to get started?" Because it was that fast and they were sleeping through the entire thing.
Well, thank you. That was the most important thing. When I had mine, they put the IV in, and I said to the doctor, and he said, "Well, I want you to count down from 10. I said, "Well, how long will this take?" He said, "Well, I've been finished 30 minutes just waiting on you to wake up." I want to encourage people that it's not horrible, despite
Yeah.
my fears. And let me tell you, and our next speaker is a oncologic surgeon, and she will tell you what happens if you get the cancer and don't do the preventative work and have to have a colostomy and all of that. So believe me, I'd much rather go to sleep and have my screening study done and catch things early. That is what is most important. Michelle, are there any questions in the chat box for Dr. May?
Yes, there are. And thank you so much, Dr. May, for your presentation. I learned so much just now.
I hope
So there's
so.
about 4 questions. So an easy one for you probably, but how does alcohol play a role in colon cancer?
So the exact mechanisms are challenging, and we think that it is laced with the reality that the heavy use of alcohol is related to other lifestyle factors that are leading to toxins that build in the colon over time. But alcohol use is associated with many bad conditions, the most important being chronic liver disease. But in addition, we know that heavy alcohol users are more likely over the time of their lifetime to develop colon cancer.
Okay. And can you recommend an easiest way to get third-party payers to approve colonoscopy in Blacks under 50?
Yeah, this has been a challenge. It's because of the guidelines that vary by the guideline societies. So I mentioned United States Preventive Service Task Force, American Cancer Society. They all have slightly different recommendations. I like to use the United States Multi-Society Task Force. So that's USMSTF. And if you put on your insurance justification that you're using the United States Multi-Society Task Force recommendation that Blacks be screened at 45 with colonoscopy, because that guideline says with colonoscopy, it is often approved on that.
And that was USMSTF?
United States Multi-Society Task Force, exactly.
Got it. Okay, thank you. And then is FMT of any value in treating ulcerative colitis?
Oh, this is a hot topic. So this is the concept that we can do a transplant of the microbiome from a healthy individual to someone who has chronic disease called inflammatory bowel disease, specifically ulcerative colitis. This has nothing to do with colon cancer, but it's another common disease that we deal with as gastroenterologists. And there are some studies that show that FMT, or fecal microbiome transplant, is effective in patients with ulcerative colitis. But there are some studies that raise concerns. It depends on where you get the fecal transplant. It depends on how well it's done so that it's given to you safely so you don't develop any side effects or bad effects from a poorly conducted transplant. So I would talk specifically to your IBD specialist about what they have at the health centers to which you have access to see if they've done it and to see exactly what the outcomes have been for their health system.
Okay, thank you. Do we have time for a couple more, Dr. Maxey?
Go ahead with one more.
Okay. Let's go with what is recommended for screening an 88-year-old female with bright red blood in stool?
Yeah. So we recommend screening for all individuals age 50 to 75 or 45 to 75. After 75, we have to start thinking about the risk of colonoscopy. Colonoscopy is safe, but as we know, when we get older, our heart and our lungs tend to be taxed. And you can have unfortunate events during colonoscopy, and that rises after a certain age. So at around 75, it's an individual conversation with your primary care doctor. And we do that until around 85. So that's the 10-year period that it's a one-on-one discussion and a one-on-one decision. After 85, we don't screen. However, if someone's having bleeding, that's considered a diagnostic workup. And in that case, the provider might actually think that it's okay to do a colonoscopy if the patient does not have severe heart or lung disease, is not on blood thinners or any medications that would make the procedure more complicated. So yes, I've screened 95-year-olds, a healthy 95-year-old I have not screened, but done a diagnostic procedure on. So we do it sometimes. And again, it's more about your background health.
Thank you so much. That's critical information.
I appreciate your fantastic talk. And hope we can be around for some questions.
Yes, I will stick around. Thank you.
Thank you. And we're going to have our oncologic surgeon in just a moment. But we were unable to get Pastor Sabine Jones on earlier due to technical problems. I believe that he is able to unmute now. I'd like to introduce my spiritual pillar, Dr. Sabine Jones. And we make sure he's unmuted for a 2 to 3 minute talk about how this affects our community. And hopefully he can be encouraged to give us a short musical rendition. Pastor?
Can you hear me?
Yes, sir.
Praise the Lord, everybody. Praise the Lord. Thank you so much for all of the wonderful information that we're receiving. And we're excited about every opportunity to have a chance to share in such a communication. I am Pastor Chevy Jones of Atlanta, Georgia, and I am very much impressed with all of the things that you are doing, particularly relating to informing Black people about particularities of the diseases that most impact them and how we can go about getting good treatment. I've been reading a series of books recently entitled Operating in the Courts of Heaven. And it talks about an effective, effectual, productive way of praying that I was not previously aware of. But it speaks of the third commandment, I think, which says the sins of the father visit upon the children of third and fourth generation. And it talks about that in such a fashion that the diseases and the sicknesses that have been encumbered by the ancestors will be visited upon the children, second, third, and fourth generation. I'll talk about that another time. But there's a section in his writing that talk about how to treat these diseases from a spiritual point of view that does not differ with the science. But I'm looking forward to having a chance to test out a little more, maybe in a month or two after I've gone a little further and had some chances to test it out, to come back and to share with you the results of what I have found. And I'm looking forward to hopefully being able to do that in such a way that it'll be a blessing to the African American community. Father, we thank you for this chance to be among these scholars today and doctors and researchers. And we pray that you will give us an opportunity to grow in grace and knowledge and love and be blessed by what they have learned and what they practice in the art of medicine. We ask you to continue to bless, preserve, and keep them and hold them in the hollow of your hand. And also give them the information, Father, the understanding, so that they can share it with those who are in need of what they have come about and that have come to pass in their learning and in their lives. In Jesus' name we pray. Amen. You say a small song, you said?
Yes, sir.
Okay. Can you hear that?
Yes.
Teach me, O Lord, to do thy will. Take me out of self, my wounded body heal. Teach me, O Lord, and I will obey. Where you lead me, I will follow. Pride Chapel, remember that? Teach me, O Lord, to do thy will. Take me out of self, my wounded body. Teach me, O Lord, and I will obey. Where you lead me, I will follow. So many things we don't understand, but we know who holds tomorrow. And if we put our trust in your hand, you will lead us to the promised land, the promised land. You've shown me the way so many times. Many times I've looked the other way. But now I'm trying with all of my heart to be what you want me to be. I wanna be ready when you come. Teach me to do thy will. Take me out of self, my oh Lord. Teach me where you lead me. I will follow. That's enough.
Thank you so much, Pastor. You calmed my soul today, and I appreciate you coming on in short notice, and we've been blessed by you. Thank you so much. I want
God
to
bless you.
thank all of our participants. We're going to go to a very good friend of mine who's the product of Cincinnati, Ohio, where I grew up. And just as an aside, I went to a school that was sort of on the wrong side of the tracks, a hoodlum type school. But Dr. Cutter went to the school for smart kids, and she has been a force to reckon with in Los Angeles as a new young surgeon. Uh, she trained at Cedar Sinai. She does oncologic surgery, and the thing that I like about her, we talk about prevention.
Yes.
We talk about diet and those things. But there are many of us who don't do the prevention part right. And when you don't, she's one of the people that you're going to meet. But hopefully, from her talk, we will help lower that rate of people who have to meet the actual surgeon. We say that the pathologist is the last doc. The surgeon may be right before that. Dr. Cutter, please take the floor.
Well, thank you, Dr. Maxey. I appreciate that warm introduction, and I'm glad that there's some Cincinnati energy here on this call and during this presentation. And, you know, the other speakers have done an excellent job of really setting the stage for what I'd like to talk about. I organized a grand rounds earlier this year, and I recruited a medical oncologist and a radiation oncologist to talk about the dichotomy or the dilemma that's represented by choosing cancer care versus and staying away from COVID-19. And you know, the thrust of that is that it's important to continue to see your physicians and to proceed through the steps that are necessary. So Dr. Mitchell and Dr. May were excellent at laying that out. And I'm going to be referring to some of the things that they talked about as we progress. Okay. All right, so what we're going to talk about today, we're going to start off talking about elective surgery and what that really is and talk about some new terminology there. And then I'm going to talk about what I'm calling the blueprint for Black lives, where it relates to cancer and cancer care. So those are the two major topics we're going to review in the time that we have. So I want to start off with talking about this competing risk because this is a very serious situation. I think it is disproportionately impacting people of color because we do have some healthy patients with curable cancers that feel that they have to choose between a COVID-19 risk and getting their cancer treatment. And what's happening is that there are a number of treatment delays or cancellations, whether it's curative surgery or access to venous structures so that they can get their systemic therapy or chemotherapy and even their radiation therapy appointments. And one of my colleagues, actually from San Diego, was saying, she's an OBGYN, that she had started to do primary care during COVID-19 because so many primary care offices had closed and weren't serving their patient populations because of their concern about COVID-19. I am proud to say that my fellow Cincinnatian, Dr. Maxey, is like myself. We stayed open throughout the entire pandemic. We're still seeing patients and we're not going to stop, right? We need to see our patient populations, but there are some physicians who just stop seeing patients. And, you know, hospital shortages also have an impact on what we're calling elective surgery, whether it's supplies or available space in the ICU if it's a big surgery. And there's even been some shortages in terms of the COVID-19 testing. We used to test everybody in the emergency department with a rapid test. And now what we're doing is we're selectively giving a rapid test for people we think need procedures or surgeries. And then we're giving the longer test, which takes about anywhere between 3 to 5 days to get a result with others. So let's jump into this whole concept of what elective surgery is. There's 3 basic classifications: emergent surgeries, urgent surgery, and elective surgery. And these are based on scheduling and the timing of when surgeries perform. So emergent surgeries are not really that difficult to figure out. That's like your appendicitis surgeries and things like that, or perforations. Those need to be done within a few hours. Urgent surgeries need to be done within a few days. Those are bowel obstructions and some incarcerated hernias and some other things like that. And elective surgery is basically everything else. You can wait weeks, you can wait months. It just depends on the type of surgery needed. But I want to introduce this topic to you, and if you're squeamish, avert your eyes, because I have some examples of what we're calling elective cancer surgeries. The first one on the left is a metastatic breast cancer. That's actually not the breast, that's the axilla. That was an 11 centimeter metastasis to the axilla on the left side from a very small, it was only about a 2-3 centimeter breast cancer in the left breast, but the lymph node grew so large that the center of it opened and was extruding cancer cells from her axilla, causing her an infection and putting her in the ICU with infection and no alternative for treatment. And I happened to be doing some contract work that week, and being a surgical oncologist, I said, you know, I can take care of this. The next one here is an advanced anal cancer. Not only is it in the anal canal, but it is extruding out of the opening. The one in the middle, the large one, is a sarcoma of the back. That one started off as 2 centimeters, and this patient was entered into a study. The study was not successful in taking care of her. She came out of the study and ended up landing with me through a plastic surgeon, and she had a 14 centimeter sarcoma on her back. Skin cancer is the next one. That is a squamous cell carcinoma that started off as just a little tiny mole that several other physicians thought was benign. And then it just grew over a period of 2 years until he presented on my doorstep. And then the final one is a tongue cancer, where a squamous cell cancer had completely replaced her tongue, completely, from the tip of the tongue toward the back of the throat and down to the base of the tongue. So everyone, these are examples of elective cancer surgeries. And I just submit to you that these are not optional. And actually, if you are going to delay these elective surgeries, what happens is you have unresectable cancers. And what does that mean? That means that these are cancers that we cannot remove because it's not indicated, right? Once the tumor has gotten to be too extensive, then we can't take that out. So why not? Why can't we remove those? Well, there's something called carcinomatosis, and that's basically what you're seeing in the lower photo. And that shows basically like the polka dot appearance of cancer along the lining of the abdominal cavity as well as on the bowel. Locally advanced tumors, some of those are resectable, but some of those can erode into blood vessels and that cannot be removed. And so therefore you cannot take those out. And then metastatic disease. Now, there's another talk I do on how we handle metastasis in this current age. There's a lot of metastatic disease that we can remove and take out, but in general, metastatic disease kind of pushes the patient into a different category, and someone like Dr. Mitchell would then go forward and treat those patients. So I just submit to you that elective surgery for cancer does not mean optional. It means something different entirely. So there's a new terminology that's emerging. It's called essential cancer surgery. And these are surgeries that, number one, where it cannot wait 2 to 3 months without the tumor progressing. In other words, without the tumor either getting large, becoming more invasive locally, or spreading to remote sites. And the other category is to relieve suffering. So we call these palliative surgeries. So these are surgeries where someone has an obstruction or some other issue, and the surgery can help with those symptoms, palliative surgery. And so if we talk a little bit more about essential cancer surgery, we can look at it in terms of the organ type. So these are some of the organs where if there is a cancer there, these surgeries are not considered elective cancer surgeries. They're considered essential cancer surgeries. So this includes the brain, and that's mostly because the brain is in a confined space. You know, the skull is only so large, and the more that a tumor grows inside, the more that it pushes normal brain aside and can cause some long-term issues, as well as breast cancer, especially in those triple negative patients. Those are patients with the negative estrogen receptor as well as progesterone receptor, and HER2/neu negative as well. Stomach cancer, or what I call gastric cancer, that's one of the areas that I focus on, is gastric cancer. Those cancers can be very aggressive, and they can extend from the stomach up into the esophagus or down into the small bowel and become very quickly something that cannot be removed. Pancreatic cancer is very unforgiving. We've heard some current cases of some well-known people who have not survived those. And so the earlier that you can remove an abnormality in the pancreas, the better. And I would submit to everyone, definitely if you have some type of issue in your pancreas and there's some uncertainty, continue to have that evaluated until the question is answered. Liver surgery as well, bladder cancers, renal cancers or kidney cancers, and also lung cancer. Lung cancer is another one that's very unforgiving. And unfortunately, because of the extra capacity that we have in our lungs, it takes a long time before a lot of those cancers to come to our attention. And a lot of those patients are not resectable, and they present at advanced stages. And again, those are patients that someone like Dr. Mitchell would take care of, a medical oncologist. So what happens during COVID-19? What are some of the cases where it's okay to delay surgery, where, you know, surgery does not necessarily have to be performed? Well, we call this selected cancer surgery, and it may be delayed if there are other equivalent treatments. So for example, systemic therapy like chemotherapy, or targeted therapy, or hormonal therapy. And keep in mind, these are all therapies that circulate throughout the body, and they go to pretty much all of the tissues. And so that's why we call them systemic therapy. And that's, chemotherapy is a component of that, okay? And so someone like Dr. Mitchell would provide that, a medical oncologist. There's also radiation therapy as another option. Another reason why a surgery might have to be delayed is if the resources are constrained. And that's primarily if there's not enough ICU beds. Some major cancer surgeries really do require post-operative ICU stays. They need that intensive care attention and monitoring to make sure that the patient is recovering adequately. So constrained resources is another reason. And then finally, if the infection risk is greater than the risk of the cancer, that would be a situation where cancer surgery would be delayed. But one thing I will share with you is that in my situation, being here in Los Angeles, and it is a larger city, it's been relatively uncommon that we haven't been able to operate on cancer patients. And in fact, cancer surgery is one of those elective surgery loopholes that we're seeing in the hospital. So if you're in a location where you need cancer surgery and people are telling you that it can't be done because there are no elective surgeries, I would recommend to you to first get a second opinion, and second, see if you can get into another healthcare system, either in your city or in another city, because these surgeries are being performed, they're being performed safely, and as Dr. May pointed out, there are a lot of precautions being taken in the hospital to protect not only the patient, but also the staff, the physicians and the nursing staffs that are working in those places. So let's begin to construct what I'm calling the blueprint. And this is the blueprint for those of you who may be impacted by cancer or know someone who is. We don't just want to treat it, we'd like to avoid it. And Dr. Maxey knows that prevention is a very big hot button for me. And it's a really ironic because the better prevention is, the more it's going to put me out of business. But I'm okay with that because health and wellness is the primary concern. So let's talk about what happens to get you to cancer surgery. I believe Dr. May and also Dr. Mitchell kind of touched on this, that unfortunately there are some inequities that are happening in terms of treatments that are being offered to patients of color. And so I know that some people may be a little bit apprehensive about surgery, and we can talk about that later in the questions if we need to. But if you need it, it's important to get it, okay? And the longer you wait and you put it off, the more likely it is that you're not going to be a candidate. And you don't want to be in that situation if you do change your mind. So the first step is screening and or symptoms. So we've already talked a little bit about screening. I have another slide on that a little later, so I will touch on that, but I can't emphasize how important screening is enough, because screening is our pathway to getting people treated early. But also symptoms are important. Things that Dr. May discussed, like bleeding, but there's also some other situations, things that don't look normal on our skin surface, the way that we feel inside, unexplained pain, growth, things that are not even in terms of sizes. All of these things should bring to mind that we need to seek additional attention. The next step is diagnosis and staging. Diagnosis typically happens with a biopsy, and then the pathologist will take a look at that biopsy. And a biopsy can be anything from a needle going into a tumor to having something called a core, which is something that's longer and larger, to actually having some type of a procedure, whether it's an open surgery or a laparoscopy. And I do my biopsies both ways. I either do them with a minimally invasive approach or with open surgery to do biopsies. And then after that, we take the information that we get from the biopsy, the information that we get from imaging, and together we can do staging. And I have the TNM in parentheses next to that. And that's the typical format of staging that we use. T is for tumor, N is for lymph nodes or nodes, and M is for metastasis. And depending on the tumor type and the presence of one or all of these factors, we can come up with a stage. And that's where the staging, stage 3, comes from that we heard about with Chadwick Boseman. Now, step 3 is a decision for surgery. So I like to refer everyone to a fantastic resource, and it's called NCCN. NCCN stands for the National Comprehensive Cancer Network, and they produce a set of guidelines every year for upwards of 50 to 100 different types of cancers, and that's usually by organ system. But the reason why I'm referring you to these guidelines is they have a version for us, for physicians, and then they also have a version for patients and their families. And so these are written in a way where you can read through them, get familiar with the cancer type, you can get familiar with the treatment options, and you can get familiar with the pathway that you're taking. The reason why I think this is so important, and I encourage all of my patients to look these things up, and I spend a lot of time educating my patient. And the reason why is I want every patient to be empowered to make their own decisions. As physicians, we throw a lot of information at you, and we give you a lot of different visual things and descriptions and all of those things. And then we say, well, would you like to have surgery? It's hard to make a decision like that. You don't always know all the issues and factors. And so I think things like the NCCN guidelines, and the American College of Surgeons puts out a series of literature as well that do a great job of at least getting you on board with the terminology and getting you to a point where you can at least begin to understand some of the factors involved as well as the pros and cons. And then finally, I'm a huge advocate of a second opinion. I do a lot of second opinions. I do telemedicine as well as face-to-face. And I actually have some colleagues that I refer patients to for second opinions on things like radiation or systemic therapies. But what a second opinion does is it gives you a chance to ask a whole different set of questions than you did with your regular physician and get a different perspective on your treatment plan. In that way, you can begin to understand the pros and cons of the pathway ahead of you. And it gives you a chance to really get educated and to make a great decision. So I really do encourage the second opinion. Now, I did say I would talk a little bit more about cancer screening. So I brought this up because I wanted to really just touch on the key areas. You know, most of our screening is focused on breast, colon, and prostate. And we do know the ages that we need to begin this screening. Those were mentioned by Dr. Mitchell a little bit earlier. But I do want to emphasize, I think it's important to begin these discussions very early. And I know that, 40 is a long way away from 45, but the reason why I say begin these discussions at age 40 is by the time it's time to do the screening, it's important for you to understand all the issues surrounding it, how to make a decision should something be positive, whether or not you'd like to get screened earlier than the recommendations. If you wait until 45 for something that is recommended for 45, well, guess what? You're behind the 8 ball. But if you start those discussions earlier and ask for information, things that you can look up on your own, by the time you get to that age group, you're ready to go, okay? So I can't emphasize that enough. I also wanted to mention that it's September and it's not just my birth month, it's also Prostate Cancer Awareness Month. So I'd like to encourage everyone, men and women, to learn more about prostate cancer, encourage the men in your life, and men, encourage yourself to get that digital rectal exam. It's just a 1 minute of discomfort that can save you from months or years of discomfort. It's an important step and something that's easy to do. And as soon as it's over, you're done for a whole year. Finally, I'd like to just touch on lung cancer screening. This is something that's really not done very often, and a lot of people don't really realize that there are screening recommendations for lung cancers. In general, it's about age 55 is the beginning of that time frame, and it's in people who have smoked for about 30 years. So big time smokers and people of a certain age, you fit into that category, and the screening test of choice would be a chest CT. All right. And the only testing I didn't mention was for the breast is the mammogram, but I think you guys already knew that. All right, so that is the screening slide, and I will be talking about symptoms and everything at another point. Okay, so this is one of my favorite topics, and that's prevention. How do we prevent cancer? Do we really know specifically the exact things that we can do that absolutely guarantee that we will not develop cancer? Unfortunately, the answer to that is no. But what we do know is that there's certain habits that can reduce our risk. I talk to my patients about something that I call honor yourself. And here it's spelled HONERRE because it's an acronym. And I have a slide on that next, so we'll go over that in more detail. But I highly recommend you honor yourself. The next is get to know your body, know your bowel movement habits, know your urinary habits, know your sleeping patterns, know your digestion. All of these things are very important because when there's a change, you need to mention it to your doctor. And more importantly, I think you should keep track of it. Sometimes people come into the physician, their primary care physician, and they say, oh, I haven't been feeling right. Well, tell me how you've been feeling. Well, it's hard for me to describe. That's difficult to work with, but if you keep track of it a little bit, you'll be able to say, I've noticed that I haven't been sleeping the same amount. I've been waking up at 4 a.m. I've had, reflux disease that I've never had before. I can't eat as much as I used to. That's something called early satiety. That's a sign of gastric cancer. So I just welcome you to get to know your body. I mentioned it earlier, but find a primary care physician you can trust. somebody like Dr. Maxey, who is very much invested in your care and wanting to make sure that you're going to have an excellent outcome. The final strategy is something that's kind of near and dear to my heart. This was touched on earlier today, but it's elimination of obesity. Now, this is not about getting skinny or becoming a supermodel or anything like that. What eliminating obesity and comorbidities, and by the way, comorbidities are just medical problems. That's another word for it. But by eliminating these two factors, you really do reduce your cancer risk significantly. One thing we're noticing is that patients who are on the obesity spectrum are having higher cancer rates. There's some understanding as to what's happening. There's some thoughts about the pluripotential stem cells that are in adipose tissue. What did I just say? That there are stem cells in your fat tissue that can be targeted by different hormonal signals in the body, different things we eat, environmental conditions that can support the development of a tumor. There's some studies that even say that obesity is replacing tobacco or smoking as the #1 modifiable risk factor for cancer. I find that stunning, that obesity can replace tobacco, something that we've heard about for years and years as being the worst thing that we can do, and now being overweight seems to be overtaking that as something that's even worse. So because that's so near and dear to my heart, I'm actually in the process of earning a certification, and I'll take my exam next year to become a certified obesity medicine physician as well. And I'm including obesity medicine in my practice in terms of supervised weight loss and recommendations for patients to become healthy. So these prevention strategies are very important. So what did I mean by honor yourself? Well, again, this is a much longer talk and I can't go through everything, but I will give you what each of these letters stand for. Adequate hydration, organ detoxification, especially the liver, can't emphasize that one enough, and the kidneys, very important. Nutrition. Nutrition is one of those fuzzy words that we use, but I have some very specific criteria and guideline about what constitutes adequate nutrition. Exercise is very important, and that doesn't mean that, hey, I walk around the house a lot, that should count. No, it's sustained exercise, 20 to 30 minutes, several times a week. But again, more details later. Adequate rest, that's associated with healthier outcomes, and inadequate rest is associated with obesity. Imagine that. This is something that we don't really talk about a lot in medicine, but this is part of my acronym, and that's relationships. It's important that we detoxify our relationships. And if we can't detoxify our relationships, we just need to detoxify our life. And that means reducing the stress, whether it's coming from significant others, work, friends, family, what have you. There are ways to be in the storm, but not of the storm. So this is very important. And I think this is a little bit of what Pastor Jones was talking about when he made his comments about praying differently and how that can be healing, because when you get into that prayerful mode, or when you're in a meditative state, whatever it is your belief system supports, you are more at peace. And when you're at peace, there's more rest and digest, which is supportive of the immune system, and less fight or flight, which is the antithesis to the immune system. So that's the impact of stress. And I think stress is one of the major contributors for African Americans and their higher rates of malignancy. And finally, environment. Ms. DeRosa did a great job of talking about what to do to keep the home environment in a relatively clean state, especially from the air quality standpoint. But there's some other factors to consider. Our fabrics, what we put on our bodies in terms of lubricants and scents and things like that, all of that does make a difference. And again, I go into that in more detail in other settings. I cannot do it all today. So this is the blueprint that I see for Black lives, is first to follow the 4 cancer prevention strategies that I outlined. The second is to begin cancer screening discussions at an early age 40 is what I say, or if you have any symptoms, to begin discussing those with your physician and tracking them yourself. And then finally, if you do get a cancer diagnosis, complete all the steps for cancer treatment. Make sure you make it to the finish line. People may not offer you all of the cancer treatments. But if you go to the NCCN guidelines or to the National Cancer Institute web pages and things like that, you can begin to find out what treatments are really indicated and get second opinions and find a way to get the treatments that you're due. I really want to thank everyone for joining me today and listening to my comments. I'd like to open it up to questions if it's appropriate at this time. But if you do have any questions, you can call my office. And I also have a website if you'd like to send in something electronically. But thank you very much for the invitation, Dr. Maxey, and I'm turning it over to you.
Thank you so much for your excellent talk, Dr. Cutter. I knew it would be that way, and I'm going to invite you back several times. I want to ask some questions of you. First, Michelle, are there any questions in the chat box?
There certainly are. Do you want me to go ahead with those, or do you want to?
Go ahead and start.
Okay. So is there any evidence that intermittent fasting reduces cancer risk by forcing the body to digest damaged cells and other waste in the body in the absence of food?
Well, I'm going to answer the question this way because I do get questions from people about fasting, eating one meal a day, things like that. I think if you're at a point where you know that there's something going on with your liver and you need to detox your liver and you feel that, this detoxification process includes fasting and it's under a supervision from your care provider, I think that that is okay. But let's just think about things from just a basic standpoint. It's just like your car. If there's no gas in the car, it's not going to run very well. If you cheat it of oil or the other lubricants and things like that, there's going to be wear and tear. And so the fuel for our bodies is nutrition. And I advocate 4 to 5 servings of vegetables every day, 3 normal size servings of protein every day. That's what the body needs to have the building blocks to repair itself. So it depends on what your objective is and what state you're in. Not state in terms of the United States, but state in terms of your body state. And so I recommend that if you're going to do something like that, do that under supervision.
Okay, thank you. You mentioned several different types of cancer. We know that there are several different. There was a question to say, what about adrenal cancer? Do you have any comments about adrenal cancer?
Well, adrenal cancer, the good news about adrenal cancer is if you can catch it early, it's very treatable. The standard of care for surgery for adrenal cancer at this point is a laparoscopic removal. In other words, minimally invasive, several small incisions in the abdomen. And I'm holding up my fingers. This is about 0.5 centimeter to 1 centimeter and working in that environment. And some people do those with the robot. I'm very much an advocate of robotic surgery for specific surgeries. And adrenal surgery is one of those that I think can benefit from robotics because the adrenal glands are very difficult to access and they're difficult to see because they're small in certain cases. So I think with adrenal cancers, as long as it hasn't spread all over and it's very limited, those can be removed. In fact, if someone finds an adrenal mass on imaging, if it's over 3 centimeters, the recommendation is to have that removed. So those of you who have been to the emergency department for another reason, and you get a CT scan of the abdomen and pelvis, ask for a copy of your CT scan report and pore over that. Look up the words that you don't understand. And if you see something like that, a 3 centimeter adrenal mass, then you know you need to go and get additional attention.
Okay.
Let me make a comment, and then I want to open the floor to all of our speakers.
Okay.
First of all, I thank you, Dr. Cutter. This is great. You mentioned several things that I'm going to ask you and the group to comment on. One of the major ideas I had by having these talks is to present top-notch Black and minority physicians discussing topics that will help save our lives. And you mentioned second opinions. It's my thought that we should have a panel of doctors like Dr. Cutter Dr. May, Dr. Mitchell, and many others that you met, doing formal second opinions. And we will have this introduced next week, that we put together such a thing where you can have credible information, credible access to people who, I've often said, people don't care how much you know until they know how much you care. And the Black Health Trust is going to be offering, I won't say exactly a certifying exam, but we want to make sure that physicians that we bring in front of you are not only clinically competent, but culturally competent as well to talk to all of us. We know that there's a lot of discrimination in deciding who gets what, and our doctors will take the time to do that. Let me ask, in the interest of time, all of our speakers today, let's go around the table and have them make a few comments, and then we'll go back to questions. Let's start off with Dr. Mitchell and Dr. May and Dr. Cutter, and Dr. Desiree DeRusso on the areas that you talked about. I'd like some final comments that you have on those issues. Dr. Mitchell? Okay.
I'm not seeing Dr. Mitchell. She may have lost connection.
Gladys Greer. Rep Gladys Greer.
Okay.
She may have lost connection.
Can you open for Dr. May? I need to call you back, Dr. May.
I'm here. What was the specific question?
I wanted to know, in light of our discussions today and what you've heard, not only from yourself, but the other speakers and some of the questions that have been asked, are there any other things that you'd like to address or say regarding cancer and COVID, and also the issue of racism? I'm concerned that, for example, many of our community don't get the best recommendations for treatment. In cardiovascular studies, we know that many of our people don't get offered the appropriate heart operations. Many of them have unnecessary amputations. Many of them don't get the cancer treatments of choice. And knowing your position in dealing with health equity, and in a way, I disagree with that term, health equity. I think it ought to be optimal health. We don't want to just be equal to other people. We want to have the optimal health that you can obtain for yourself. But I'd like your comments on some of those issues.
Yeah, thank you. I actually think we covered quite a bit today. I'm just impressed that we were able to look at the full spectrum, from diagnostics to treatment, even risk factors, and also in the setting of COVID. And I want to emphasize that even now, when we need to be cautious of where we expose ourselves and where we're out and about, you can't delay these critical health checks. Cancer is not going to wait for COVID to end. I'm hearing too often patients telling me on the phone, I'll come meet you and do that after COVID. It might be a year or two before we're back to normal, before everyone's vaccinated. So I'm really just trying to encourage people to see their doctors now for their routine care and get the screening that they are due to in a timely manner, and not wait for after COVID. Because there's so many studies that are already projecting that we're going to have 10,000 additional breast cancer and colon cancer cases than we would have had if we were not in the COVID pandemic. And those are due to delays in screening and delays in care. So that's the number one thing that I want to emphasize is about healthcare professionals. I think we're doing a bad job of teaching this in medical schools. And I know that I went through medical school quite some time ago, but even when I was going through, health disparities were just coming on as a topic that would be integrated into the healthcare curriculum or the health learning curriculum. We're doing somewhat better now, but I would say even so, we're far underperforming. So there needs to be more attention to this, not just for Black providers, but for white providers, because the majority of Black patients will see a white or non-Black provider. So it's not just about me educating the other younger doctors that look like me. I'm making the effort to make sure that I'm educating the white doctors, the white male doctors in particular, that are populating our medical schools and that are going to go on and take care of my family members.
Thank you. I have one more question to add on to that. Uh, in recent months, I've had the privilege of discussing healthcare with a number of doctors who specialize in integrative medicine and functional medicine. And in fact, I've got several in the queue to give talks in coming weeks. And I actually want to have some people with NPIs have a discussion on some of the treatment issues. Uh, do you have some thoughts over allopathic medicine, which those of us who went to medical school mostly have, and those who treat patients with functional medicine, so to speak? Do you have any thoughts on that? And we're going to do that later, but I just would love
Yeah.
to do on that.
I think Dr. Cutter probably has a lot to say on this as well. What I will say as a gastroenterologist, not so much in the realm of cancer, because cancers most times need to be cut out or treated aggressively. But I take the majority of patients I see have irritable bowel syndrome, IBS, or have functional bowel disorders. So chronic pain, chronic changes in their bowel movements, chronic bloating. Those conditions are very often treated very well with untraditional approaches. So we use things like massage therapy and meditation. We use yoga and peppermint oils. And we know that there's a strong connection between the brain and the gut through the brain-gut axis. And that if we treat mental health and mood, that it also treats abdominal pain and chronic diarrhea. So there's a lot there that we're learning about. There's still much to be understood, but we know that there's a component of non-traditional therapies that we probably haven't optimized.
Thank you. Dr. Cutter, you want to pick up that lateral?
I really do. And thank you so much, Dr. May, for passing me the ball. But, I'd like to bring up one of my relatives. I have a relative who trained at the University of Michigan. He was a medical oncologist. And when he finished his training, he began to inquire not just about the medical treatments that he learned in medical school, but he also invested himself into study of alternative therapies. And so he became a behavioral oncologist. So I found him to be just amazing. And this is like 30 years ago. So he was way ahead of his time. And in fact, what his philosophies were about really preparing the body so that the immune system functions optimally. Now, all of us who treat cancer, we like to think that it's something that we did that fixed the problem. And what I always tell my patients is all I'm doing by performing surgery is giving your immune system a head start. Okay, I'm not really fixing the problem because all I can do is cut out what I see. And it's the same thing with Dr. Mitchell. All she can do is give systemic therapy, check some imaging studies, and see if there's anything that she can see. But what about all of the things that we can't see? That's the job of the immune system. So that's why some of these other things, like what Pastor Jones was talking about, these alternative therapies and everything, I think that's where those come in, because those are the things that really prepare the body to fight off those residual cells, those things that are in the bone marrow that we cannot see. When I did my research fellowship at Memorial Sloan Kettering, these are some of the things that we looked into in terms of stem cells and what's in the marrow and what that contribution is to developing either recurrent disease or metastatic disease at a later time when we thought that the cancer was eradicated. So yes, I do think there's a role for those other therapies, but here is my caution. And I just had this conversation with someone who saw me for a very large gastric cancer. She was very much afraid of getting chemotherapy and getting surgery and all of those things. And she said, I really just want to try alternative medicine. And I said, you know what? If you do, you're going to need to radically change every single element of your life. You know that acronym, that HONOR acronym? That's what she would have needed to have changed. Hydration, exercise, sleep, relationship detoxification, organ detoxification, all of those things for alternative medicine to even have a prayer of working. And by the way, your tumor is so large now that your immune system just cannot catch up. So surgery is going to be a way for you to get a head start and to get back in front of that. So to me, that is the role of alternative therapy. I think it definitely does have a role. And like I said, when I was at Memorial Sloan Kettering in New York, we actually had an alternative medicine branch, a department that focused on that. And I trained there, my gosh, that was back in 2003 to 2005. So that's been around a long time and it's been embraced in a lot of environments. So I do think that there is a role, but it has to be well defined.
Thank you. Dr. DeRusso, do you have any comments?
Um, Again, just to reiterate, incorporate outside air if possible, at least minimum 15 minutes a day. Make sure units are serviced. That includes duct cleaning, wiping off registers, where the air blows out from the wall. Run air conditioning units if you have them continuously, if possible. Clean fans, don't point them, at people. Also, what I didn't mention is UV light. If you could use portable UV lights near fans and or have them put in ducts, that cuts down on pollutants, bacteria, as it does in surgical applications. And it's something that a lot of commercial air conditioning units and ductwork have. So that's it.
Thank you. Is Dr. Mitchell on? Well,
I'm still not seeing, no, I'm still not seeing Dr. Mitchell. I don't know.
I'd like to, first of all, thank our guest speakers for an outstanding set of talks and information. And I will send you my written communication thanking you for this. And I'm going to also invite your participation in our advisory and in our second opinion in one way or the other. I'd like to remind everybody, as I do every week, that we've heard the high end of what we must do medically, but there's the regular end, which means wear a mask, which means washing your hands with soap and water, being careful to remember that this virus and other contaminants can last a long time on surfaces. So there's just a lot of common sense things that we have to do to protect ourselves. We know that those of us who are over the age of 60 are more likely to have a fatality if we get sick. We know that young children do carry and potentially spread this virus. We know that there are even people in their 20s and 30s that have caught the virus and have died. So nobody gets away. I also believe that because of structural racism, there's a lot more that we have at risk. We don't often have the jobs that will allow us to shelter in place behind a computer. We're the ones out there wiping behind in hospitals, cleaning hotel rooms. So we have to be careful. It is so very important. Again, I'd like to thank everybody. Michelle, is there one short last question in the chat box?
Oh my. Okay, one last question. Yeah. Okay. Well, please comment on the growing risk of burnout in essential workers during this pandemic. So I think that addresses how can we take care of our healthcare providers.
Dr. May?
That's not a short question, Michelle. No, I think it's real though. It's something that we're thinking about a lot. I work at UCLA Health. We're seeing we've seen quite a burden of COVID since March. I'm fortunate in that I'm not on the very front lines and that I'm not running our ICUs, but my colleagues who are, I'm checking with them daily because they are burning out. And we very early activated a lot of our specialists like me, like our endocrinologists or rheumatologists, and just made people aware that you might need to cover some of these services that you haven't covered before, which, I think people were a little terrified about, but these are things we've done before. We've had formal training in ICU care. We didn't get to that point in Los Angeles. New York did. My colleagues who are gastroenterologists in New York, they were working in ICUs, taking care of COVID patients. We didn't get to that point here, but I think we're just trying to be very cognizant of the fact that we can't continue like this forever. We're trying to make sure that the shifts are short and that people are taking vacation. We're trying to stay ahead of the curve. Right now, the big concern is COVID plus flu. So we know that we might have another big uptick if we do see both of those infections occurring together.
Well, thank you so much. I appreciate everybody here. I'm going to do something a bit unusual in closing out. Like I say, we are not a religious organization, but we do celebrate spirit and we do need togetherness. I'm going to ask Ms. Brenda Lee Ager to give a short dismissal word, followed by a short benediction from Pastor Jones. Ms. Brenda Lee Ager.
I am here, and I'm just overjoyed at these beautiful, beautiful women and men who we don't get to know. We get to know one doctor or two doctors in our lifetime, but it's so nice. So I just want to leave you with this: only believe, only believe. All things are possible if we only believe. So the power of God protects us. The love of God enfolds us, that wherever we are, whatever we're doing, God is, and so it is. I love you all, and thank you very much.
Pastor Shabine.
Praise the Lord, the believing Brenda. God is wonderfully blessed by the presentation of all those persons who, out of their experiences and information retrieving, have brought to us a wonderful approach to living life more fully and coming out of from under these devastating pandemic experiences. The Lord bless you and keep you. The Lord make his face to shine upon you, lifting up the light of his countenance upon you and giving you peace now and evermore. Amen.
Thank you. Thank you. Remember to go to blackhealthtrust.org. I think you can register and send us your email on that. Thank you, everybody. Have a blessed day. Have a good day.
Thank you to all our presenters. We couldn't do this without you. Thank you so much. Take care of yourselves.
Happy trail.
Happy trails.